He's Googling.
Yeah, I don't know. All right, let's get started. Whoever's late is late. At any rate, I wanted to start with a story. So today's Grand Rounds is going to be a loose Grand Rounds because it's not really Grand Rounds. I'm just filling in for Dr. Maniji, who canceled. There is a lot of discussion, as an understatement, in the stroke world right now about what to do with these new studies. I just came back last week. I was in LA, where that's all that everybody was talking about. And so I thought I would share my own view. Partly I'm going to share some of the discussion that's going on in the meeting, and then I'm going to settle on my own view, and then we're going to discuss a few cases. And I think you'll be surprised at where this ends up. To begin, I was thinking last night, this story really began 20 years ago. This is the end game. This is, I consider that we are now at the end of the beginning of stroke management. Okay, that's, I think, the right characterization. This started 20 years ago. 20 years ago, two things happened. TPA was introduced by people like Jim Grotta, Tony Ferlin, that sort of thing, in the NIHSS trial that was reported at Christmas of '95. And then the same year, 95 and 96, Steve Warwick, Greg Albert, Lee Klostergaard, and myself all started to work on diffusion imaging and not just work on it, but apply it in humans. And those two things created this 20-year revolution, which we are now at the end of. The other part of it was, so let me go through the case with you. So first of all, we reported, I don't know, in '98 maybe, we reported that on a long series of patients, all done with a single stroke protocol and MRI, we reported a somewhat surprising finding, and that was that at 6 hours, 25% of the people had a penumbra, which was 9 times the core. So in other words, 90% of the patient's neurologic deficit was reversible. Okay? And another 25%, the penumbra was 3 times the core. So in more than half the people, at least 3/4 of the tissue at risk had not yet undergone infarction at 6 hours. And this sort of, that's what I'm saying, that's what started this down this path, was this notion of core and penumbra, and the penumbra being a metastable reduction of blood flow that had not yet produced infarction. And we have time, so I'll tell you the original story. The original story goes back to 1977. And there were 3 neurosurgeons at one of the first stroke meetings. They were in Sweden. And I actually know one of them, so this is secondhand. Okay, I wasn't there. But there were the 3 of them were sitting doing what neurosurgeons do at stroke meetings, that is, with their feet up, drinking brandy and smoking cigars. So one of them, a guy, so his name was Busiju. So he says to the other, including Tony Strong, who's a friend of mine, so he says, hey, you ever do and remember, this is 1977, no CT scan, no MRI, nobody's ever seen a stroke in vivo, okay? So Boo says to Tony, he said, hey, do you ever do an endarterectomy for a guy who's had an MCA stroke, and after the endarterectomy, the stroke goes away? And Tony says, yeah. And Boo says, well, what the hell's going on? That was exactly what was said. And the 3 of them looked at each other and came up with this notion of the penumbra, which was they wrote a letter to stroke in 1977, and the name of the letter was, Is Sleeping Beauty Dead? Okay? And they said, in it, they proposed, and then Busiju in 1981 actually published a paper in Animals in which he demonstrated the biochemistry of the penumbra. And the concept was that you have normal blood flow, you have reduced blood flow, and then you have infarction level blood flow. And infarction level blood flow is 10% or maybe a little bit more of the normal blood flow. And if that happens, the tissue is going to infarct. But if you're in the 30% range, the tissue will run acidotic, you have excitotoxicity, it falls electrically silent, and so it contributes to the neurologic deficit. But because glucose utilization is continuing and ATP stays up in that tissue, despite the acidosis, the tissue isn't infarcted yet. And if you reverse the ischemia, that tissue can go on to be preserved. That was the penumbra. That was a concept that they introduced. And we now image the penumbra with perfusion-weighted imaging and diffusion-weighted imaging. in 2001, so to finish this story, in 2001, I was interviewing, so I was ready to leave Stony Brook, and I was interviewing at the University of Wisconsin. And I gave basically the same talk that I would give today. There's not much has changed in the last 20 years, truthfully. Better tools, which we're going to talk about, but the concepts are the same. So I was interviewing, I gave grand rounds at the University of Wisconsin during my interview visit. And I saw the interventionalist leave about 3/4 of the way through the grand rounds. And I figured he got called to do something. At the end of the grand rounds, he comes back in and he says, "Did you believe what you just said?" And he was like, "That's a queer question." Yeah. He said, "Well, let me tell you about a case." And he had a case that was in the hospital who had an embolus 17 hours earlier. Okay, this is in 2001, 17 hours ago, documented witness 17 hours ago. They did a diffusion and perfusion image. There was a small diffusion abnormality and a huge perfusion abnormality. And he said, "What would you do with this case?" And I said, "I'd open the vessel." "What do you mean, what would I do?" "Open the vessel and take care of it." And we did. That was the end of my interview, and instead, I just rolled up my sleeves and we took care of this guy who did extremely well. That was treating a stroke 17 hours out in 2001. So the notion that we can get to 16 to 24 hours of stroke care is not new, okay? What we have are better tools and a better way of thinking about it. But all of this has created chaos right now in everybody's thinking. And so I want to show you that from my perspective, everything old is new again, okay? That you have all of the tools that you need with nothing very sophisticated. That's where we're going to head. And we're going to take our time, and there are going to be 3 cases. So as you know, I don't usually do cases, but I thought it would be helpful to illustrate these cases on my, so this should work, right? All right, let's see if we can do this. Yep. All right. So what do we do in the modern era? That's the idea. Let's go back. The title is in the new reality. That's what everybody's talking about at in LA, was the new reality, okay? There was an excellent discussion section with the head of all the major of Diffuse 3 and Dawn and that sort of thing, and that's incorporated into this talk. So this is the era that we're now living in. Let me just turn off some lights here. Oh, no, too much. Good. All right. So here, we're going to go look at these trials in just a little bit of detail, not a lot. In the Dawn trial, the patients are presented in the 6 to 24 hours. And the result of the Dawn trial is that you can select the people who will do well after mechanical thrombectomy by delineating the core and a clinical penumbra. Not a radiographic penumbra, a clinical penumbra. Okay, Noguera, I'm going to return to some of his viewpoints. In the Diffuse 3 trial, this was Greg Albers. So this is my old friend Greg Albers from perfusion imaging days, okay? So Greg is saying that patients, and of all the investigators of Diffuse 3, it's I think 38 medical centers, that patients presenting within 6 to 16 hours will do, you can identify those patients that will do well after mechanical thrombectomy by delineating the core and penumbra with imaging. Okay? And underlying all of this is the phenomenal progress that has been made in catheter technology. That is what has changed. Now, if we look at Dawn and Diffuse, I made this table just so you could compare the two. They're not that different, but if you want to follow. So both of the trials got stopped early because there was the benefit of catheter revascularization was so overwhelming that the trials were interrupted by the safety committee in both cases. The difference in vessel, this is intracranial ICA or MCA, this is any ICA, in other words, including the proximal extracranial carotid. The timing was 6 to 24 or 6 to 16. Greg apologized for doing that. He knows now they could have done 24. It doesn't make any difference, and you'll see why in a minute. They do mechanical thrombectomy versus standard medical therapy, which would include IVTPA well, none of them in the 6 to 24 will be eligible. The exclusion criteria are a little bit different. The only exclusion criteria for Diffuse 3 have nothing to do with the stroke. They're sort of this sort of stuff. There were exclusion criteria in the Dawn trial, but these exclusion criteria basically are going to be encompassed by the inclusion criteria for diffuse 3. There's really not that much difference. If the pre-modified Rankin was greater than 1, our residents are always doing pre-morbid modified Rankin scores in order to determine who can be cooled, for instance. So in other words, the person either has to have no neurologic deficit or minimal neurologic deficit without any disability, all right, in order to go into the trial. That doesn't mean that we can't do that. We can't use this for other people, but they didn't go into the trial is all that it means. If you saw old criteria, the 1995 criteria, if you have more than a third of the MCA visible in the infarct on CT scan or MRI, then they are not eligible for the trial. The inclusion criteria are that you have to have a clinical penumbra. By clinical penumbra, I mean that when you do the neurologic exam, the old neurologic exam, okay, the amount of tissue that you envision as a neurologist, okay, involved in the neurologic deficit exceeds the amount of tissue that you see undergoing infarction by the criteria of, in this case, they were using perfusion CT. So, and I'll show you pictures of the perfusion CT. There also was a difference. Yes, Chris?
Are you going to elaborate a bit on how you clinically define the area at risk versus ischemia?
So we do this, you do this, we do this, all of us do this all day long. There's nothing different than that figures. There's nothing different than what we normally do. So if the frontal eye fields are affected, then the frontal eye fields are affected. If the motor strip is affected, then the motor strip. If Broca's area is affected, if Wernicke's area is affected, if there's a transcortical aphasia, if there's, you know, visual fields that are affected, it literally is the neurologic exam, not the anine stroke scale anymore.
Which part is penumbra, which part is core?
Well, you have to, when you do your neurologic exam, so that was the point of our 98 paper, actually. That was the point of the paper. That was that the penumbra, the area of reduced flow, so the point of the paper was that when you examine a person in the emergency room, the neurologic deficit that you are able to elicit includes both the core and the penumbra. Right. Okay? In order to separate them, you're going to need imaging that shows you what part is infarcted.
Okay, so there's not a clinical separation.
There is no possibility of separating core and penumbra on clinical grounds. So you have to identify the core. The way we identified the core was what diffusion-weighted imaging. And that still is the gold standard. There is currently, as I'm going to show you pictures in a minute, there is currently the notion that on CT perfusion, all right, that if the blood flow is less than 30% of what ought to be there, then that represents tissue undergoing infarction. Okay, that's probably not strictly true, but it's a good approximation at the level of clinical care that we're talking about. Okay? So you identify the penumbra as the maximum extent based on your exam, and then you use imaging to define the core. Okay? Which can be either by diffusion imaging or maybe CT perfusion. All right? The evidence is that CT perfusion does the job.
But here, you know, in the change of protocol, we do not routinely do the CT perfusion.
I'm going to talk about that right now. Yeah, you know, you have to break things before you know, my father would say, you can't make an omelet without breaking some eggs, okay? We got to break some eggs first, okay? However, I do want to, you can see these details, again, in the diffuse trial, again, a heavy use of imaging. And I think that's the point that I want to make, is the difference between these trials. This is superficial. This looks, those don't matter. This could have been extended to 24 and the results would have been the same. Everyone is quite convinced. That's not the issue. The issue is that this is imaging intensive and this is clinical. Okay, that's the difference. But this still requires either diffusion imaging or CT perfusion to identify the core. And I want to say that's not necessary. That's where I'm going. And that's the thesis that I'm going to develop. This is real, this becomes, in my opinion, this becomes really easy. Okay? And you'll see why. We have to develop the pieces that explain why this is easy. Let's look at the results, however, before we move on, because the results are really pretty spectacular. I mean, this is the ability to get to a modified Rankin of 0, 1, or 2. That means at the end of the day, the person at 90 days, either the person is independent or not, okay? 49% independent with mechanical thrombectomy, 13%. 47%, or 45%, 17%. Now, let's also notice that this is, in neither case, is it half. Okay, so even now, at our best, and this is where those of you who have been close to my office know that I'm flying around the office right now because I'm very excited about doing some future research. And the future research has to do with the fact I want to deal with this 50%. Okay, this looks good. Okay, it's way better than standard. But let's be clear, half the people are not independent when it's over. That's where I want to go. Okay? So just to set that in perspective, the number needed to treat are minuscule, but for any disease that would have a number needed to treat of 3 to increase the number of people who live independently, that's a pretty amazing number, okay? No increase in mortality. Actually, in the diffuse trial, there's a reduction in mortality, not surprisingly. And then the ICH rate. They say that they're the same. They're not the same. They double with mechanical thrombectomy. Okay? The numbers are too small to make it significant. You're dealing with tiny little numbers here. But let's be clear, you're going to have more hemorrhages when you do mechanical thrombectomy. This is the rapid software. For you and 125,000, you can do this on your CT or MRI. The colors have become purple and green. What the software does is it does the kind of perfusion imaging that we published from 98 to 2004 or so, and then dumbs it down, okay? And just sets some thresholds and makes it either purple or green. And purple is less than 30% and green is less than normal. Okay? So this is the core, this is the penumbra. This is the core, this is the penumbra. Here, this is the core, not very much. I'm going to show you one of mine that looks like this. This is a penumbra with a severe reduction in flow altogether. You get actually 3 colors. There should be, I would say, an infinite number of colors because the MRI or CT scan, it's a gradation from about 20 to 100. So why are we working with 3 colors? That annoys me no end. All right, now, so the question is, what are we doing, okay, here at Einstein? What are we doing, okay? How do we react to all of this with our resources in our patient population? So let's get real, and that's what the rest of the talk is about, although we still have to introduce some basic science. Now, so what are your choices? Are we going to do 2 cats for everyone out to 24 hours? How does the stroke team feel about that? We do about 1,000 a year, right? How do the residents feel about that? You know, so we're at 750 a year with 2 a day, and the residents are going, 2 a day? We do more than 2 a day. Somebody's missing the count. But the number of calls in the middle of the night for stroke, where there's someone showed a graph of it, it's an exponential rise in the last 8 years. I mean, it's exponential, okay? What imaging do you do? Do you need MRI or CT angio or CT perfusion on everybody? And whom do we intervene? Let's be clear about some of this. Count radiation. The way that you count radiation, so I'm just going to wander around here because I'm just filling in so I can do whatever I want, right? So the way that you count radiation is, the unit of radiation is not the gray or the rad or that sort of thing. It is the radiation exposure you have over the course of a year on the surface of the Earth. That's 1. Okay? A CT, a non-contrast head CT, is 2. 2 times your annual radiation dose for a non-contrast head CT. A CT angiogram is 5. Okay? A CT perfusion is somewhere between 10 and 15 times your annual exposure of radiation. Of course, MRI is 0. Okay? So that's always been a motion. You cannot, one of the first things, we did these calculations, actually, Howard Rowley and I did these calculations, and the first thing that you realize is that you cannot do serial CT perfusion. People's hair falls out, actually, when you do that, okay? So you can't do that, okay? Which was one of the motivations for focusing on MRI perfusion instead of CT perfusion. You can't repeat CT perfusion. The radiation dose is unacceptable. Nobody thinks about that. Who is the people in which we intervene? So just a couple of statements, and we can, like Chris interrupted me, everyone should feel free to interrupt and ask whatever you want, anytime. The number of stroke calls per night, okay, we went over this, all right? All right, now this is important, and this is data from, I'm not going to show you the slides, I don't have the slides, they haven't been published yet, but there is very good evidence about this statement, and this is from both trials. There is no effect of time on the outcome of patients who are selected by the criteria that we laid out, okay, that is a small core and a big penumbra, all the way out to 24 hours. The curve is flat. That endpoint, that number needed to treat of 3 is the same at 6 hours as at 24 hours. There is no difference, none whatsoever.
With IV TPA or?
Right. This is what, okay, watch. Let me just put it with this next, with the next slide, okay? The number of patients who meet the criteria, this core penumbra mismatch criteria, is going down continuously. So that at 30 minutes, probably everyone would meet the criteria, okay? And at 24 hours, less than 15% of the strokes will meet that criteria. Remember, I said 75% at 6 hours, okay? That was a 98. We understood this, okay? So, but the number keeps going down, and by 24 hours, you really have to scratch to find a person who will benefit. But this is not nil. That's 1 in 7 people can still be moved, you know, so 1 in 7 are going to meet the criteria. Roughly half of those will be moved to independence. So it's not that you don't want to ignore them, okay?
Judge, the problem is, you know, when we're on call, the timing, 24 hour, whatever, we're always confusing, not very clear. You know, how many patients we see, oh, when is the onset? A lot of times we don't know. Why not we disregard the timing? We just do the MRI. If, you know, we identify the level, it does not matter.
Wonderful question.
Yeah, we don't know. A lot of times we don't know. You know,
Watch. Watch. Just stay with me, Ann. You're going to like the end, okay?
Yeah.
I am a minimalist, okay?
Yeah.
Now, all right, let's be clear. This is just a caveat. There's no new information here. I just want to make clear that nothing has changed about IV TPA. We're just saying that, okay? So because of all the things going on, I just want to make clear nothing changes for IV TPA, nothing at all, okay? Now, this is all driven by the new IR catheters, okay? Now, here's where you are neurologists. Think like neurologists, okay? Don't let all this stuff confuse you, okay? We're just going to do neurology. Stroke 101. You live and breathe this stuff. Now, let's translate the buzz into our language, okay? Because our language is more sophisticated than the buzz, okay? So basically what we're saying is mechanical thrombectomy applies to patients with leptomeningeal artery thrombi or emboli. The buzzword is LVOs, but it's leptomeningeal vessels is what we're talking about, okay? It does not apply to lacunes. It does not apply to the very distal MCA. It might apply to the PCA, and we're going to come back to that as a practical matter, because sometimes it's hard to tell a large PCA stroke from a posterior MCA stroke. They're pretty close to one another neurologically. You both catch Wernicke's, you both get, visual pathways, right? You both may have sensory disturbance, neglect, things like that. So they can be, I find them hard to tell apart anyway. We continue to include basilar, all right? And of course, this isn't going to apply to stroke mimics. That's almost there as a joke. But I want to emphasize that we're just talking about leptomeningeal vessels. The catheters that we're talking about are called, there are 2 classes. There's the penumbra. The penumbra is a vacuum on a catheter. And then there are stent retrievers. There's a Trevo, it doesn't matter. There are several brands now. They are equivalent, okay? They get the same results. It makes no difference what you use, except the penumbra is cheaper and easier to use. So we here at Einstein tend to use the penumbra more. Paul Brady uses both. Everyone else only uses the penumbra. It's easier to learn to use. It's a more robust catheter. The results are at least as good as the stent retrievers. And basically what you do is you put this vacuum catheter in, you grab hold of the clot and you suck like hell, okay? And it comes out, the whole thing comes out. It looks like a little gummy worm. I mean, we do that routinely. Paul comes out, he shows it. When he gets it, he holds up his hand to those of us in the room, and you can see it. It's almost as long as his fingers sometimes. I mean, they're amazing clots that you get out of especially the ICA. And then this is a stent retriever, and it's a cutting stent. What you do is you unsheath it and it expands radially, and when it expands radially, it gradually, you leave it up for 5 minutes, it bites into the clot, and then you just pull it back, and it just pulls the clot with it. And it both work incredibly well. I mean, incredibly well. The number of cases right now in which you can achieve a first-class revascularization is around 92% right now. So 92% of the time you can clear the obstruction from the arterial tree. But remember, only 50% are going to walk out independent. Okay? All right. But you have a 92% success rate of clearing the vessel. Stroke 101, this is literally from my Stroke 101 lecture that I would give to the Jefferson students over at Jeff, okay? And these are the leptomeningeal vessels. If you can see them on the surface of the brain, then it's a leptomeningeal vessel, okay? These are the vessels that we name, right? The MCA, the PCA, the A, that's what we're talking about. These are your LVOs, okay? There's nothing, don't let the term LVO hide your basic neurology, okay? You're looking at them, and include the carotid as an LVO. It's a large vessel occlusion is what LVO means, all right? It does not include the penetrators, right? It does not. You know this. So your neurology, you go, can you tell a lacoon from an MCA syndrome? Duh. Most of the time I can. You know, I'm going to be wrong a few % of the time, but you walk in and you look at the patient. Our residents do it. They walk in. They do. Our residents right now do it without examining the patient. They because of our timing, while the patient's being registered, stuck, blood pressure measured, and that sort of thing, they're doing the exam while they're looking. Okay? And we all do, and they do too. And that's the answer. This is not hard for a neurologist, okay? Here are some of the imaging proposals, and here I use the term proposals because this is from a really, really good round session that was run by an old friend of mine, Quill Turk from Wisconsin. And in it you had the head of the diffuse trial, the head of the Dawn trial, a guy from UPMC who's run another very different trial. And so here's the spectrum. I want you to really see this. This was impressive. And this is what started me thinking, was this round table. You go from one extreme of Greg Albers to the other extreme of UPMC. So look at this. Greg is saying MRI, A, and perfusion-weighted imaging on everybody. All right? Isn't that what Jan just said? He said, go get the answer, right? Here's another. These are the various things that you can do. You can do a non-con. I don't just put CT anymore because there are too many CTs. So this is the non-contrast head CT. So you can do a non-contrast, a CT angio, and a CT perfusion on everybody. You can. You could do just the non-contrast head CT and the CTA on everybody. You can do a non-contrast head CT and a selective CT angiogram. You could just do the non-contrast head CT and go directly to angiography, which is actually where I'm heading. Okay? Or you could do nothing. You could take the patient and put him, so a guy comes in and it looks like an MCA, put him in the angiogram suite. Okay? Our biplane is capable of doing a CT scan. How about that? Okay, here at Einstein, you could take the patient, if the CT scanner was down, you could put them on the angio table and get a CT scan. It doesn't have the same resolution as the one that we have in the ER, okay? But what's the differential for a large MCA stroke? And large hemorrhage, right? It'll pick up a large hemorrhage, okay? Easy enough. So then why put them in the ER? Yeah.
So the IST3 and the initial diffuse study, they did CTs, and then if somebody had a high NIH stroke scale, they took them straight to angio.
Right.
But those trials, they didn't pan out because they said that, okay, patient selection was an issue.
We're gonna come to that. Yep. And this is where, that's what the UPMC, watch a calculation that he does. I'll show you, it's interesting. So the question is, why, I mean, this is a pretty wide range of opinion out of leading stroke researchers. And the answer is, what's going on is the collaterals. And this is where you have to, yeah, I either want to reinforce this concept or introduce this concept to you, depending on where your head is right now. When I was a resident, okay, one of the things that you learned about stroke management, and there wasn't much that we knew about stroke management back then, but I'll tell you that one of the things that we did know was that that it's going to be the patient's collaterals that determine their outcome, not what we do as much as the collaterals. It's the collaterals. And basically, if the patient has, and this is still being said in this meeting loud and clear, if the patient has good collaterals, then we have time to do our job. And if they don't have good collaterals, then we have them time to do our job. When we were, I remember a case at Wisconsin of a guy that we saw about 75 minutes from last known well. We had diffusion, perfusion, imaging. They were identical. The infarct was precisely the same as the perfusion abnormality. You draw the edge, they were identical, okay, at 75 minutes out. He had a terminus MCA. He had no PCOM to that side, he had no A1 on that side, and he had no leptomeningeal collaterals. And the guy occluded and infarcted, and that was it. 75 minutes and it was done, okay? So that case certainly drove home this whole rule. And so this guy has collaterals, right? And this guy does not. Let's look at a few more of those, all right? I'm going to turn the lights out for 1 or 2 minutes. I want you to see this. Right. So this is a nice slide, took off the internet last night. And what we're looking at is 3 different patients, okay? Different MCA obstructions, a distal MCA, a mid MCA, and on the other side, a mid MCA, all right? Look at the difference in collaterals. So this is 3 phases. This is 3 moments in time of the same slice. So look what's happening, all right? The contrast arrives equally, equal density, roughly speaking, maybe trace less on this side, but pretty down minimal. But it lasts longer and persists after this has washed out. So you know that this has a longer mean transit time. Here's that. This is good collaterals. This is pretty minimal stuff. Look at this guy. Okay, he gets contrast arriving at the same time as the arterial tree on the other side, but it's incomplete, and it hangs up for a while, okay, and then it eventually washes out, and then here, this is poor collaterals. This guy gets nothing. A trickle coming through late, okay? That's bad. Paul calls this the desert sign. I'm not a big fan of that kind of description, which is why nobody paid attention to the paper in '98, but that's the way it goes. Anyway, so here's the deal. All right, now let's start to separate, and this is artificial because it's a gradient, but I just want to separate artificially good collaterals and bad collaterals. Okay, and I want you to see what happens when you think the problem through all the way. Okay. Let's take a patient with a poor collateral, and this is consensus from the meeting. This is not. Patients who have an MCA obstruction with poor collaterals are going to present hyperacutely. Once that vessel obstructs, they're screwed. Okay, that whole tissue is quickly going to become deeply ischemic. All right, and they're going to fall down to the ground with all the neurologic deficits that they can muster. They're going to have a very rapid evolution of their infarct. Okay. Could be as fast as 75 minutes, okay? This is fast stuff when you have poor collaterals. Time is critical, okay? Every single minute, I would say every single second is making a difference, okay? That's really important. You need to get your head around that. If the person has poor collaterals, you have no time for anything, okay? It's a fire drill to as fast as you can go. When this guy comes in with poor collaterals, the CT is already showing you early infarct. You can see it. There's swelling. You can see it, right, immediately on the CT scan. So, and don't worry about the dense MCA. This doesn't really belong in this whole, MCA doesn't correlate with it. The dense MCA, it's good. It's good to identify it. I mean, it's an important sign, but don't use it as a prognostic indicator is what Don't worry about it. Just, Paul's gonna empty the vessel anyway. So don't let the MCA even slow you down for a fraction of a second. Just ignore it. See it, go, oh yeah, I see it, and move on. But you already saw it on your exam. It's the left hemisphere or the right hemisphere. You see the dense MCA, it's like, duh, you know. Hello, he's got an MCA on the left. What do you want?
You know, the point here is the CT scan, you know, how much, you know, early infection or swelling you saw. Because, you know, if you saw a lot of hypodense, usually outcome is very bad. So it should be very, very early sign. Or,
Right.
or nothing.
Yeah, a
It'll
little
be great.
cortical edema, a little
Yeah.
loss of gray white, a little bit of swelling.
Just a little bit, you know, still,
Yeah.
but that's where the money is, you know. How do you look at the CT scan?
Well, you look and see if the MCA
Yeah.
is more than 1/3 infarcted, visible on the CT scan.
Done.
This turns out to, yes.
Yeah.
This turns out to be a very useful sign, okay? It correlated with hemorrhage and failure to improve with IV TPA,
Yeah.
and it correlates with failure to improve on mechanical thrombectomy.
But this is the part of
Let me
easiest
just
thing
stay
to
with
do.
this for a minute, yeah.
Yeah.
The way that
Yeah.
you say, how do I think of 1/3 of the MCA? What the heck? I don't know how,
Yeah.
you know, image analysis here. So divide the MCA into 4 parts, okay? Frontal lobe, parietal lobe, temporal lobe, basal ganglia. 4 parts. If one of them is affected, that's a quarter. If 2 of them are affected, that's a half. That's more than a third. That's always been the rule, and that still is the rule. That was the criteria in the Dawn trial. Okay? If that happened, they were out. Okay?
And this
So,
is clearly demarcated hypodensity, not just a vague.
Yeah,
change.
what you want to see is, so most of the people won't see it, okay? The radiologists never see it, okay? They never see it, okay? You see it, but
Yes.
you see it because you know it's there.
Yes.
Okay? You've already done the neurologic exam. You know darn well what's affected, and you look at it and you go, you know, I think that's turning low density. Okay? The radiologist is, the ER is coming over and says, radiologist says it's clear. And you go, fine, okay, I'm not gonna argue, I'm not even gonna talk to them about it. I see it, but I see it because man sieht, was man weiß. You see what you know. You know it's there anyway, okay? So, low, however, I wanna be careful. We're using a low radiation CT protocol right now, and so you have some false positives, if you will. CT scan is very difficult to read. And that's why I'm saying most of the time it's going to be called normal, but when you will see it. But if you see it and you look and if the radiologist calls and says he's infarcting his frontal lobe and his basal ganglia, okay, you're not going to help this person by revascularization. Okay? All right. The MCA, so that was an MCA with bad collaterals, right?
If we don't want to ask one more question.
Sure.
For the previous scan, the thing is that when, you know, I'm on call, sometimes, you know, work with the resident is like this. M1, we know how to do it. The problem is like the M2, superior division and inferior division. And then the superior division, we saw a little bit of hypodense, but the inferior division looks good. And we saw kind of the stuff. So next time we're debating, we want to save this M2. Next second.
Go get it.
Yes,
Go get it.
that's kind of thing, you know.
And the speed, and here's, so, go get it is the answer.
Yeah.
And the speed with which you go get
Yeah.
it, that is the time that you take for additional imaging,
Yeah.
okay, is depending on when he's presenting. Because if he has poor collaterals, you don't have time, okay? If you see that happening at 75 minutes,
Yeah.
okay, after last known well, you better get your butt down to the mechanical thrombectomy.
Yeah, that's why we like the CT angiogram together. At least we can look at the collaterals.
Stay with me, Ann, stay with me, okay? So let's go on to the patient with, so we're gonna get to the cases and you'll see what happens with the cases, all right? Here's a guy, so that was poor collaterals, here comes good collaterals, right? So the guy with good collaterals presents acutely with a relatively stable deficit or a fluctuating deficit or an improving deficit. He comes in, we saw this last week, right? And he comes with an NIHSS stroke scale of 21. You get the CT scan and you re-examine him and he has an NIHSS stroke scale of 15. The question was, did he have a seizure? Okay, I'd say re-examine him again in about 5-10 minutes. Because if he went from 21 to 15 because of a seizure, then in 10 minutes he's going to be at 9. Okay, but if he's at 14, it's not a seizure. okay? He's had a stroke, and he's fluctuating because he has good collaterals. That's what's really important about this. So we went over this weekend. The system was, they had 6 major strokes, including 3 mechanical thrombectomies this weekend here. And it was a busy weekend. And the cases were very challenging cases. And in one of them, they went from an NIH stroke scale 21 to 15, literally, but the next NIH stroke scale was literally 14. And they were worried about a seizure, but I just say, that's not how a seizure behaves. A seizure doesn't do that. A seizure does this, right? It just, if they improve over a 15-minute period, 6 points on the NIH stroke scale, because they're post-ictal after a seizure, they're gonna keep improving. But the stroke doesn't. The stroke may improve as the collaterals come in, right? And the deficit shrinks a little bit. That's it. It doesn't completely reverse it, and so they ended up with an NIH stroke scale of 14, and so you know that you're dealing with a stroke. By that time, they had a CT angiogram which showed an occluded vessel. But I'm telling you that the time course, this is neurology, the clinical neurology is going to drive this, not the imaging, okay? That the time course distinguishes the two. All right. MCA with good collaterals, they have a persistent penumbra with a stable or slowly growing core. The time is important for this person. You don't want to be fooling around here. But the time frame is now might be minutes, but many minutes. Not minutes to seconds, but minutes to hours. Because they might be coming in 6, 7 hours late. They may be a wake-up stroke. They may be a time unknown stroke. That's this group, okay? And the CT, here's the key. The non-contrast head CT doesn't show the guy has the last known well 7 hours ago or witnessed stroke 8 hours ago, right? And you put the guy in the CT and you see that little bit of density like we were just talking about with Jan, and you're thinking, this should have been there at an hour. And I'm here 7 hours out, and this is what I'm looking at? With an MCA stroke and an NIH stroke scale of 26, and that's it? You know, and the radiologist is calling and saying it's normal, and you're going, it's not normal, but this is not. I mean, this doesn't make sense. It doesn't make sense because he has good collaterals. So you need to intervene, okay? And you can intervene. That's the key, is that he hasn't undergone major infarction. Forget the time. He hasn't undergone major infarction, but he has a large deficit. So he has a big penumbra and a small core. And that's the criteria that you're looking for to do intervention. But you learned it from your neurologic exam and a non-contrast head CT. You haven't done CT angio, you haven't done MR, you haven't done any perfusion imaging. You just examined the person like a neurologist ought to, and looked at a non-contrast head CT. So you see what I'm saying? It's like, really? And that went, by the way, from poor collaterals to good collaterals. They both ended up the same. So that's, now you start to see where I'm going. So this is Nogueira, who was the PI in the Dawn trial. He said this out loud. He stood up and began his talk in the round table by saying, he said, here's the best LVO detector I know, and he put up a picture of one of his colleagues. Right? The best LVO detector is a stroke neurologist. It's someone with experience taking care of stroke. That's who is the LVO detector, okay? Because it's the leptomeningeal. You know this, right? We teach this. Like I said, you teach this to Jefferson medical students, okay? That it's an MCA distribution, you know, face and arms, bearing leg, that sort of thing, and higher cortical function. That's the MCA stroke. Neglect. You don't see neglect in the Coons, right? Okay? Aphasias, okay? I mean, yeah, occasionally, you know, pulmonary strokes will do that, but that's rare. The NIH stroke scale is generally higher than in LeCun's. You can have a complete hemiplegia, so these are not firm rules, but you would recognize a LeCun anyway, all right? And the CTA or the MRA both show the LVO, the large vessel occlusion, and they also show you the collateral pattern. So it doesn't matter if you use MRI or CT scan as far as the information goes. I'm just putting this up to remind you what we're talking about. Now, here's the question that was raised by both Nogueira and the UPMC doctor, whose name I don't know. And how many times have the residents heard me say this? The CT angio adds, I've been saying 14 minutes, turned out to be a gross underestimate. It's 24 minutes. So if you just take the people who go CT angio versus CT plus CTA angio, The CT angio adds 24 minutes. This is published literature. And MRI adds 73 minutes. Okay?
So Barrows in Arizona, they published their data of a 12-minute MRI for stroke.
I can do that, okay?
They've been doing again and again and again and.
So
they've
yeah,
gotten
at
it down
Wisconsin,
to
we had the MRI machine in the ER,
Yeah.
okay? I can do that. We use a 9-minute protocol, okay? You can just do the diffusion image, okay? You have 46 seconds, okay? You still have to put the patient on the table, you have to take them off the table. You're gonna add, and that's an MRI, that's a fast MRI in the ER with a team that is used to doing that. So yes, okay,
Yeah, so I
it's
think it's
conceivable,
just a
but
system.
our MRI is downstairs, down the hallway, often with a person already on the machine, okay? It adds, so the data, this is the data from the diffuse trial and the dawn trial. The data is 73 minutes, okay? That's the data.
I don't care the data for this, the CT, I just want to know the ER, Einstein ER, before we order the CT.
24 minutes is,
Yeah,
absolutely,
Yeah.
absolutely.
24 minutes.
Yeah.
Okay.
I mean, I keep pointing out that residents, come on, show your hands if I've said this before.
No, I think it's 10 minutes.
You know
Yeah,
that.
if you do CT, CTA combined, it goes down.
It doesn't go down by
No,
30
the
minutes.
thing
We
is-
were doing CT.
Sorry,
It doesn't go down.
this is debate, okay? That's
Probably around
impossible.
15
These
minutes.
people
to
with
12
24 minutes, it was a combined CT and CT.
Nothing personal, this is just for debate. The problem is how many times we have the CT scan, we add up on the CTA. That seems very
Yeah, well,
upset.
right now our protocol has everybody getting CT angio, and here's, now, watch this, okay? Here's a UPMC doctor. Again, I apologize for not knowing his name. So, okay, so first of all, the collaterals, right?
Yeah.
We've already said that whether the person has poor collaterals or whether the person has good collaterals, the neurologic exam and the non-contrast head CT provide all the information you need to make a decision about whether you want to go to IR or not.
Sometimes we're not sure, that's why with the CTA, tell me, oh,
That's
this is
that's
collateral.
very rare, Yan. Yes, and we're gonna, but, okay, stay with me. So the guy from UPMC is going like this, look, all right, he's saying, I don't need this stuff to identify who should go to IR, because most of the patients who meet the criteria that I just laid out of a big deficit on neurologic exam and a small non-contrast head CT infarct, most of those people should be going to IR. If you took everybody, this is all data-driven, this is all, if you took everybody and just took everybody who met those criteria and put them and took them down to IR, okay, 17% would not meet the criteria for dawn or diffuse. Of those 17%, 16% of those 17% will have a complication. Your complication rate, if you just took everybody and did it IR, your complication rate is 2.7%. And you did that and he used the term punishing everybody else to get the imaging while you waited and waited 24 minutes or 73 minutes. And he's saying, count that up for the 83% who should have been treated 24 minutes faster or 73 minutes faster. And count up the number of neurons that have died while you're getting the imaging that you didn't need. This is his argument, okay? And it's a very powerful argument, okay? You can like it or not like it, okay? I'm not saying it's right or wrong. I'm saying this is a serious argument that has to be taken into consideration. These are correct. This is what you're doing. To miss this complication rate, you're subjecting everybody else to a longer imaging protocol than you need.
17% that will not benefit, I presume those are the ones that don't actually have a large vessel occlusion, is that correct?
So say that again, Chris. I couldn't quite hear.
17% who will not benefit, are those the ones with?
Those were 17% who would not have met the dawn or diffuse criteria.
Okay, but which clinically are those patients?
They are people who probably have more infarct than you would like to be treating.
Okay, so
They have LVOs, but their stroke is more advanced than
So
you think.
where are the patients that say have no evidence of CTA blockage? And do they automatically go on through those trials?
So, no, in the trials, everybody had to have a demonstrated CTA or MRA blockage.
Yeah.
Of either the M1 trunk or the ICA.
Right, so how would we eliminate those patients without doing it?
Because those people, so there, first of all, there are two things. So most of those people will not have an MCA syndrome. If they're only dealing with, again, your neurologic exam is usually, you know the limits of the neurologic exam as well as I do.
Yeah, but the neurological exam points to the penumbra, not to the blockage in the artery. So that's where I'm having a little trouble.
Right, so let's say that you do. So first of all, okay, I mean, and we're gonna get to this, but first of all, if you are in a 3-hour window, you're gonna give them IV TPA when you start. All the people who qualified in other trials, these trials were not in that window, but in other trials, which were 0 to 6 hour and mechanical thrombectomy, in all those trials, if they qualified for IV TPA, they did get IV TPA, and the evidence of a meta-analysis was that they do better if they get the IV TPA. So you do give IV TPA if they're under 3 hours, right? If you, let's say that you're wrong, that you're out at 8 hours, you have a guy with an MCA syndrome, no ICH, and non-contrast HCT. You take him to angio on the basis of that, and you do a diagnostic, you run the angio to look at the MCA, and it's open.
Yes. Well, you put them through a procedure.
You put them through a procedure with a complication rate in the range of about 0.2%.
Angio is around 1% risk or?
Not even 1%. Less than 1% complication rate.
I just wanted to sort of see what numbers of patients we're going to be running like that, because the cost there might start.
It's extremely small. It's the number of false. So I've seen them, but most of the time when you see it, they've received IV TPA, and my assumption has been that actually the IV TPA simply opened it up. And in some cases, I have a CTA with an occluded vessel, IV TPA. You get the angio and the vessel's open. I've seen that happen repeatedly. Okay, even the basilar, that will happen if you're early enough. And of course, you're early when you're dealing with IV TPA. Nothing is going to be perfect, right? Yeah.
I think that the reality is the residents are the ones who do the exam, so not the stroke neurologist. And then, especially early July, then if we don't have CPA, it's actually hard for the attending over the phone to understand what exactly going on.
In which case, the attending ought to get his ass out of bed and come join you in the ER. That's what I would say. Right?
No, not the residents, the residents are great.
I think, and I would argue, Annie, that by September, every resident in our program can recognize an MCA stroke.
Yeah, I would disagree. I think the point is that you have to know the strengths and weaknesses of your center. So I've worked at both Maine and Montgomery, and I know the strengths and weaknesses of both. And I know that, you know, during the day here, we have IR, so we could skip a lot of this because I'm looking at the patient, I'm here, Brady's here, we can do this. Versus Montgomery, I'm relying on the ED, I'm getting, you know, it's just more complicated. It might be in the middle of the night. I feel more comfortable ordering a CTA. So I think you can't replace common sense and you can't replace, you know, every case is different, in my opinion. I don't think it's
After 10,000 cases,
Yeah.
I would agree with that statement. No two have ever been the same.
Yeah.
There's no question about it. The question is, what do you do? Okay? So
But
let's
having a systematic practice in place reduces times, rather than doing individualized for each
I
case.
know that you feel that, Sri, but I don't agree with that. I think skipping the CT angio and going straight to IR is faster than doing a CT
I mean,
angio.
if you see a dense MCA sign or it's a large vessel, like it's,
When you have a neurologic exam that shows you an MCA syndrome.
yeah, if
you
they're
have your
aphasic,
answer.
yes.
George,
But stay with me, just
Stay with
stay
me,
with me,
stay
stay
with
with
me.
me, okay? This is, by the way, this is one of my own slides. So, do you love this imaging? Yes, I love this imaging. Look at this. This is a 14-minute MRI. You have a vessel, you have a tiny little core, you have a big penumbra and multicolor array. It's beautiful. Don't you feel good when you go treat this person? You do. That's beautiful. I mean, you know, I worked on this for, I don't know, 10 years. It's gorgeous, you know, it's like, Oh, I love it, but I don't know, that my first conclusion was that it wasn't, that as beautiful as that is, it isn't necessary. And that was 98, I felt it wasn't necessary anymore. And we actually demonstrated it with a series of a study which looked at you didn't need it. No one needed it. No one needed the perfusion imaging and to take care of the patient. Okay, the radiologist didn't need it to see the stroke, we didn't need it to see the stroke, and we didn't need it to make a decision. Okay? I would not say that of the angiogram. I think the angiogram really gives you a lot more certainty. Okay? And all right. So here, this is at the national level. Should all these patients go to a comprehensive stroke center? Quick calculation shows that in a small city, the university hospital would pick up 770 additional stroke unit admissions a year, which the small university hospital said there's no way we could handle that. Okay, so it seems cute, okay, but if suddenly you closed Einstein, Abington, Drexel, and every other hospital and sent them all to Jeff and Penn, they would be overwhelmed. The hospital would be, they would have no room for anything else, basically. It's not realistic to say this right now. You can say it if you want, but it's not realistic. So, all right. So we're finally to the cases. So let's look at these cases, and this is for case discussion now. So now I'm just gonna put the case up and y'all are free to comment. I have questions for you. You have a 54-year-old right-handed African-American male who presents with a typical left MCA syndrome. He has an NIH stroke scale of 26. He's 2 hours after witnessed onset. Okay? Got it? His imaging non-contrast head CT shows a developing infarct in the left temporal parietal junction, quite localized, maybe in the left frontal lobe. The radiologist says no. The basal ganglia are certainly delineated. Okay? Here's the question. Do you need additional imaging to decide what's going on with this patient and how to treat the patient?
You might need to show the CT scan.
There is no CT scan.
Oh.
I made the case up. These are conceptual.
That's all. I'll take a look. Yeah.
Do you need more imaging?
No.
No.
Patient.
All right. Anyone want more imaging? Anyone need more imaging to know what's going on? Okay. What are his collaterals?
Pretty good.
Pretty good, but probably not great. He's 2 hours out and he's already showing some infarct.
But it's not complete.
So not wonderful. Okay. Not maybe okay. Maybe not so okay. Not wonderful. If he's 2 hours out and he had wonderful collaterals, you wouldn't see anything on the
Wouldn't this be
CT.
50%?
Pardon?
Wouldn't this be 50% by the criteria you proposed earlier?
No.
Oh, just the one.
Yeah, he's definitely less than a third.
Completely. It's not completely.
All right.
The basal ganglia.
All right. Would you give this guy IV TPA? And he's going to give him IV TPA? Yes.
Oh, I-
Okay. When would you give him an IV TPA?
Right now.
Right now.
Or-
Okay. Fine.
No,
Right
blood
now.
pressure, blood
No.
pressure.
Right now. It's a good. You're mixing it. You're mixing it while you're taking him off the table. Right. Okay. Would you call IR?
Yes.
Annie, stay with me. Would you call IR on this case?
I will.
Yes. When would you call IR?
Right now.
Right now. Okay. Where does he go after the thrombectomy?
Step down. Step down.
Nursing home.
Goes to the, no, I mean immediately after thrombectomy. Where are you arranging a bed for this person?
Go to step down.
On the neuroscience unit, you're not sending this person to the ICU. Absolutely not.
Wow.
Because they can't do neurologic assessments serially in the ICU. You don't have a team of people who will take care of the people. The only people who know how to take care of this patient are nurses in the neuroscience unit. There's nobody else in the hospital who can take care of this patient.
So
Trust me.
in Montgomery, I'm assuming we.
And Montgomery, they're going to go to the ICU. We don't have the step-down level stroke unit that we would like to have at Montgomery, so he's going to the ICU. And good luck.
I would transfer them here.
From Montgomery.
No.
So if
from
they're from
Montgomery.
Elkins Park, they come here, okay? You can give the IV TPA, you can call the mechanical thrombectomy, they're coming here. At Montgomery, we prefer not to transfer
No,
them here,
just TPA
although
and
I think,
here and take it from.
did we need, my point is, could we make the decisions that we needed to make without additional imaging?
Yeah, but
This
someone.
I'm not saying that,
During the daytime when we are all here and someone's looking at the scan while the patient's on the scanner, this is great.
And that's what needs to happen, and that's the standard for here.
Yeah.
That
but
is the standard for here.
Let's say someone's in the ICU, rotating in the ICU, how many times have they not been able to come down for a stroke? They've had to send the resident first.
We should be
Does that
seeing
happen?
it. We should be seeing it day or night. I asked, and let me stay with that point right now. Okay. When do you call, in this case, when do you call the stroke attending?
Right now?
On their way to the CT scanner, okay? On their way to the CT scanner. I need to have my computer up and running if I'm at home in the middle of the night. I don't want you to call me after the CT angiogram and ask me what's going on, okay? I want you to call me before the CT is done. Okay? I want to be called when you're sending the patient to the CT. For this patient, I want you to call immediately. You're looking at him on the triage stretcher and you're picking up the phone and saying, you need to wake up, okay? We're going to be doing this in a couple minutes, okay? So that it's going to take 5 minutes for me, my home computer, to get to Synapse, okay? So therefore I need that 5 minutes as the patient's moving the CT, because the decisions are going to be made as soon as the non-contrast head CT goes up. When do you call IR? Immediately. I look at the non-contrast head CT, you tell me that you're dealing with an MCA, and I'm saying, then call IR, okay? You have to do that.
Ask a question. Let's say this patient goes for CTA-CTP.
Say it again.
Let's say this patient, I'm on call and I say, let's do a CTA-CTP, if we can. And there is no penumbra.
So
None.
why would there be no penumbra, though, Sri? Here's a guy with an NIH stroke scale of 26.
Because the CT
and
changes
almost-
aren't showing up yet.
I
but the
would say
patient has already-
more likely the acquisition is poor and you have a bad scan. That's what I would say. That is more likely to occur than that this guy would not have a penumbra.
Because in the first few hours after stroke, aspects has been shown to be very undependable, right?
Undependable.
Yeah.
Okay.
So you could have areas that are already infarcted that you're not seeing well on the CT, but
Correct.
you do a perfusion and there is no penumbra. Are you
Correct.
going to take this guy for a
So I studied 1,500 consecutive patients. No, but I mean, I'm serious. With diffusion and perfusion imaging, every single one of them who didn't have an MRI contraindication. Because our scanner at Stony Brook was right next to the ER. So everybody went in. I mean, we were developing it, and everybody went on. I've never seen that. I've never seen that. With an NIH stroke scale of 26 and a small core, I've never seen anyone without a penumbra. Never. I mean,
So usually with the
1,200
AFib and poor
times.
collaterals,
Pardon?
many times with the AFib and poor collaterals, those are the patients that come in and by the time they get
but
on
you
the
will
scanner.
have, so what you will see in that case is a prolongation of the mean transit time, a responsive increase in the blood volume, and a normalization of blood flow. So if you're only looking at blood flow, I agree that there will be times that you won't see a penumbra.
Look at
But
the
if you look at the
volume
mean
and the
transit
mean
time,
transit time.
if you look at the mean transit time, you'll always see the penumbra. It's the mean transit time that is sensitive to the penumbra.
George, this is important. Let's stay here a little bit.
No.
No, let me say, what make you make sure when you look at the scan like this in 2 hours, okay, this is neural examination, how do you so confident that this is not complete stroke?
I'm not confident yet,
Yeah.
okay? I'm only confident that he hasn't proceeded to a level of infarction,
Yeah.
which will expose him to a major complication of mechanical thrombectomy. That's all that I'm comfortable with. But, am I willing to take this guy, look at this guy, has presumably actually fairly poor collateral.
Yeah.
So this guy's made it into the ER in 2 hours. Do I really want to take half an hour and decide whether to treat this person or not? I don't think so. I need to get going.
Yeah.
It's like the analogy that I always thought of. I mean, I was a running back. I played varsity football in college, if you could believe that. And I was a running back, okay? And what you learn is that if you wait to see the hole open up and then go at the hole, it's closed by the time you get there. The play is that's where the hole is. You have to run at that hole and hope that your guard does the job and the hole opens up as you get there. That's how you treat stroke.
So everything I agree with you, but looks at scan is very, very important. That's why the CT scan, if you saw something, it's evolving, if it's complete normal,
New case.
that's a different story.
New case, all right. Notice that the only thing that's changing is in yellow. Okay, everything else is the same, including the questions. Steve. All right. 54-year-old right-handed African-American male who presents with a left MCA syndrome at 7 a.m. after going to bed at 11:30 p.m. the night before. So, same NIHSS stroke scale of 26 is the same guy that we looked at who came in 2 hours ago. Now he is 7.5 hours out. Okay? The non-contrast head CT shows a developing infarct in the left temporoparietal junction and possibly in the left frontal lobe. The basal ganglia are still delineated. Same CT scan. Okay? All right? Do you need additional imaging in this guy before you can make a decision as what to do?
Well, I'm not gonna give TPA because it's outside the window already.
So you're not going to give IV TPA, you made up your mind. Fine. Fine. Are you going for mechanical thrombectomy?
Yes.
Yes. Okay, fine. So then the answer is you don't need additional imaging, you just made up your mind. Okay? This is a first-year neurology resident, okay? What do you expect this guy's collaterals are?
I mean, it's been so long, and it's decent.
Not a whole lot of infarct for 7.5
Yeah.
hours, is there?
That long.
So he probably has good collaterals. Did you need to see the collaterals? No. You know that
You
they're
did
there.
not mention the NIHSS score, this one.
Huh? 26. Same as before. Chris?
This is a waking stroke. You don't actually know the status of the heart.
Correct. Correct. Let me stay with you. You know, okay, does it matter?
No, it may not matter,
Ah,
but
okay.
you're saying that you know that they're good, but
That's all I'm saying, is that and if they're bad, am I still not going to mean, to mechanical
just
thrombectomy?
answering the question.
I'm going, that's fine. But you agree that it doesn't matter, okay? Either way, you've made up your mind, you're not going to give IV TPA, the time window is wrong, okay? And you are going to mechanical thrombectomy. What, Steve? Okay, you've already answered, no, you're not giving IV TPA, you are going to IR. When do you call the IR attending?
No.
Now, immediately, okay? All right? Where's he going after his thrombectomy? Neuroseptic. Yep.
So this assumes that this wake-up stroke happened at whatever.
11:30 p.m.
No,
not at
that's what Chris is
12
saying.
o'clock.
not at 6:30 a.m.
Yeah, okay.
But if it occurred at 6:30,
So we have a confounding situation here, right? And that's exactly what Chris was saying. So I got two possibilities that are both, neither of which is excluded here. Either his stroke occurred a long time ago and he has really good collaterals, in which case I'm going to mechanical thrombectomy. Or the stroke just occurred and he has really poor collaterals, in which case I'm going to mechanical thrombectomy.
but you would give him TPA first.
I wouldn't give him IV TPA unless I knew unless I knew the onset. Now, of course, and the residents know this, you ask the question, did you get up at night to pee? That's a really important question, okay? Yes, I got up. And when did you get up? I don't know. It was between 4 and 4:30 in the morning. And how were you? Well, I made it to the bathroom and back. I was fine. Okay, IV TPA while you're heading to mechanical thrombectomy. Agreed. All, however, John, okay, how much imaging did I need? No additional imaging. I just asked him if he peed, okay? I know you know this. I know you know this and do this. This is what we do. This is clinical. That's my point, is that you're doing neurology, guys. One more case, okay? 54-year-old, right, same guy, typical MCA, after being found down at home, almost a full day after he was last seen well. Okay? Different guy, NIHSS stroke scale 26, again. His non-contrast head CT shows a developing infarct in the entire left MCA distribution. The whole thing, you're looking at it and you're going, okay. Who's up? Dylan. Does he need additional imaging for you to make decisions? No. What do you figure his collaterals are? Not enough. Whatever they weren't enough, right? Given the time of the severity of the ischemia, whatever it wasn't enough, right? Are you going to give him IV TPA? No. Are you sending him to IR? No. Okay. Where's he going?
If he's protecting his airway, probably he will step down, but if it's not, then I see.
He's probably going to step down. You're probably gonna start 3% sodium chloride, you're gonna manage him for his ICP. He's only 54 years old, this guy's, or you're gonna cool his hemisphere. We'll get to that another day, okay?
Possibly.
Did you need additional imaging? No. So here we went from an acute presentation to a subacute presentation to a chronic presentation where all we used was our clinical exam and the non-contrast head CT. So let me just summarize this for you, okay? In the hyperacute patient, you identify the LVO clinically, okay, by the typical pattern. And you might include some PCAs, which, by the way, we have a penumbra that will go into the PCA, and we could try to revascularize that patient anyway. So no problem if you get the PCAs in there, it's okay. You notify the IR attending immediately, okay? Immediately, as soon as you see there's no hemorrhage, IR attending. If he presents hyperacutely, then IR is immediately available. You initiate the IV TPA infusion, this is hyperacute, and you move directly to IR, no CTA. You call Paul, I've already called Paul as the non-contrast head CT is coming up and I'm seeing no hemorrhage, and I have Paul on the phone, and he says, I'm in between cases, send him down. No CTA. No CTA. Send him down, okay? If he says, I just got home, I'll be back in 20 minutes, might as well get a CTA. One of the residents have heard me say this. If you have time, use it. Just use it. Do something useful during the time. Don't sit around waiting. Just do something useful. In this case, doing something useful is getting that additional information that you would like, okay, and activate that immediately. Just to activate it immediately. When he says, okay, I'm on my way in, then the resident's responsibility is to do 2 IRIA. If the patient is a wake-up stroke or time unknown and the non-contrast head CT shows less than 1/3 of the MCA and the patient has a deficit, which is way beyond what you're seeing on CT scan, you're in the same situation. You can notify IR. If you want, because you have a little bit more time, maybe, you can obtain a CT or MRI, MRA, depending on when IR is ready. Frankly, if IR is ready, I'm sending them down anyway. Okay? If the non-contrast head CT shows more than 1/3 of the MCA distribution infarcted, das Lied ist aus. The song is over. And I don't need, you can get whatever you want, it makes no difference. So the take-home message are that, number one, the H&P, including the time last known well, when combined with a non-contrast head CT, is probably sufficient to make a decision in at least 90% of cases.
Could we qualify that a little bit? I mean, I think it's very clear for an MCA, for a left meningeal stroke. The majority of the strokes I see are not so clear.
Right.
They are NIHSS from 4 to 12 or in that range.
There's no
Well, you don't really
aphasia.
know.
Right.
And I don't think that would be, how do you want to modify the treatment?
Correct. So if you didn't have, then I would get additional information. And if I were in a,
Okay.
I think you can miss some because you might be very so here, picture, just plain old do neurology, okay? You have a clot in the proximal MCA. It's affecting the lenticular striates, right? You have really good collaterals out on the surface, so he doesn't have any cortical abnormality on exam, okay? It looks like a leucoma. That would be a false negative by the criteria that I'm setting up. So in that case, you might want to get a CT angio or an MR angio, depending on what's available.
For a clot that's balancing.
Yeah, right. So you have a lot of possibilities, and the patient still might be first of all, if he's within the 3-hour window, he's a good IV TPA candidate, so you're going to initiate IV TPA. If he's outside the window, then let's see what we got here. If that's what you have, if you have the Kuhner syndrome and the CT scan still shows that you can still see the basal ganglia, then he has an infarct of the basal ganglia yet. So one way or another, he must have blood flow getting in there, okay? And you're outside the IV TPA window. Then he's made it several hours, so he must have some retrograde flow in the MCA, must have really good collaterals, in which case you still would move towards, with a CTA would identify the problem and would move you toward intervention. So the less certain you are clinically, and that's where I'm going, okay? So just to finish, the advanced imaging, including CT angio, in my opinion, is a luxury that you use if you have the time. If you don't have the time, then don't use it. Don't get it. You don't need it. That's all I'm saying right now, is you don't need it. It gives you more information. It will always give you more information. The question is, can you afford the increased information? Sometimes you can and sometimes you can't. If you can, grab it. If you can't, move your butt and get them down to IR. On certain occasions, you don't have a good H&P, in which case you're going to need to substitute imaging. Okay? This depends on an accurate history and physical. If the patients have tunded and you can't examine them properly, none of this applies because you don't have a good exam. And that's neurology. That's all.
Good. Very
Okay?
good.
All right. John.
So part of the new recommendations are,
We're going to, Chris, I hope you're not leaving. We have a faculty meeting after this.
Application's already went.
Yeah, we need a faculty meeting, very brief, just
So-
ask them delay a little bit.
if you don't get an echo, and you may or may not get carotid, and you don't need carotid.
Brief
I
faculty.
can swallow the carotid, but the echo really bothers me.
I agree with that. Conversation for another time. Faculty, please stay. Everybody else, goodbye. Thank you. Nice to have you. Grab a donut on the way out.
Dr. Desai.